Okay.
Olivier, it's great to see you again, and it's always a great pleasure to work with students here at the Lyric. Really, the your institution had made a tremendous contribution to the art of arrhythmia care. So going forward, however, I think neuromodulation is going to be more and more important in as a part of our method in managing patients with arrhythmia. For these students, I'm going to discuss about one is mechanism cardiac nerve sprouting. So the nerves are very plastic. It can remake itself. So I'm going to talk about how that happens after myocardial infarction, and also say a few words about how electrical current will change cardiac nerve sprouting. Then that is followed by some discussions on neuromodulation for arrhythmia control. This will include electrical current stimulation to cause neural remodeling, or mechanical or catheter denervation. The sympathetic nervous system is known to be important in ventricular arrhythmia and sudden cardiac death. This is a study on circadian distribution of ventricular arrhythmias recorded by ICD. And you can see that throughout the 24 hours of the day, there's more arrhythmias, certainly in the daytime, and less arrhythmia at night. Back in 1990s, the beta blocker therapy has not been mandatory in patients with heart failure and ICD. So since then, the curve is more flattened. But before that, you can see that the distribution certainly suggests that the heightened sympathetic tone in the daytime plays a role in the generation of ventricular arrhythmia. Now, direct nerve recording, however, before the sudden death was not done until 2003. I think this is the first case, not in humans, but in a sheep, on a left thoracic cardiac nerve recording. This is by Dr. Jardine et al. I believe he's in New Zealand. And when there's a nerve activity recorded, when there is a sudden increase of the nerve activity, then the rhythm went into ventricular fibrillation. And I will not show our own data, but basically we reproduce the results in a larger number of human patients, and also in canine models that the burst of stellate ganglion nerve activity is the trigger for ventricular fibrillation. So the corollary of that is that if you are able to suppress this burst or make the burst smaller, maybe less ventricular fibrillation will less likely to occur. So what happens after? I'm sorry, I just got my bivalent vaccination for COVID. I was sick for 2 days. So the pro-arrhythmia remodeling after myocardial infarction has at least 3 different components. The first one is structural remodeling, which increases cardiac fibrosis, and electrical remodeling in the peri-infarct area, the border zone area. There are significant ion current changes that can be pro-arrhythmic. And the third arm is neural remodeling after myocardial infarction. So let's first discuss on the mechanisms of nerve sprouting after myocardial infarction. So in dogs, you can see there are major sympathetic innervation to the heart. The source of this sympathetic innervation is from the stellate ganglion. The stellate ganglion is located right at the junction in the first and second intercostal space, very close to the vertebra. And this is the ansa, which circulate, there are sympathetic nerves around the brachial artery. And the nerves then goes to the heart and innervate the entire heart. So the stellate ganglion is a main source of sympathetic innervation. Then the thoracic vagus nerve provides vagal innervation to the heart. Now, after myocardial infarction, this is a patient who is 2 weeks after myocardial infarction, and his heart was taken out during transplantation. So this is a normal myocardium this is a necrotic dead myocardium. There are a lot of small round cell infiltration. So according to pathologists, this pattern is about 2 weeks of myocardial infarction. And S100 protein staining, which stands for Schwann cells, shows there are abundant amounts of nerves in the necrotic tissue, indicating that these nerves are probably trying to reinnervate where the damage was. So this is another picture also taken by Dr. Michael Fishbein, who's my collaborator in pathology. Dr. Fishbein takes the best pictures. So this is a myocardial infarction. This is normal. You can see that there are nerves seems to be growing into the infarcted tissue. So these histological pictures convincingly show that there is nerve regrowth in humans after myocardial damage. So we try to study the mechanism by which that occurs. So this is a canine myocardial infarction model. What we did is left anterior descending ligation, which results in an MI size about 16%. Then we draw the blood from aorta and coronary sinus at different times after myocardial infarction. And the samples from left ventricle free wall and the stellate ganglion are taken at different time points. And 6 normal dogs were used as control. So the first thing we found is that there is a significant increase of transcathetic nerve growth factor. The transcathetic nerve growth factor is determined by the difference of the nerve growth factor concentration in the coronary sinus and the aorta. So suggesting that when the blood flows through the myocardium, it carries the nerve growth factor out of the heart. So this is baseline, 30 half hour, hour and a half, 2.5, 3.5 hours. You take these blood samples and analyze NGF concentration. It's a progressively increased NGF concentration. It's much less apparent 3 days after myocardial infarction to a month. But that acute changes of NGF concentration implies that this time course is too fast to have protein synthesis. So at least part of this, or majority of it, is probably pre-existing nerve growth factor. But in addition to nerve growth factor, there are many other neurotrophic factors are also increased in the heart right after myocardial infarction. So this is what happens in the heart itself. This is the messenger RNA of NGF over GAPDH, which is used as a control. So the ratio of them start to increase 3.5 hour and go up to 3 days and 1 week. 1 week L is ligation, and in some dogs we did a balloon occlusion to cause myocardial infarction. You can see that there was a significant increase about 3 days afterwards. Now, in addition, the protein level of NGF get DPH at the infarcted site is significantly increased, but even at the non-infarcted site, they can somehow get a message to upregulate the NGF protein. In response to the increased NGF protein, you can stain the nerves for growth-associated protein 43, neurofilament, and tyrosine hydroxylase. And the nerve growth factor the nerve density after myocardial infarction start to increase about as soon as a few days after myocardial infarction. It persists for a week or two and continue to be high a month afterwards. So this is the protein levels of tyrosine hydroxylase, which is an enzyme that is important to the synthesis of catecholamines. Again, so 1 week after myocardial infarction is at the highest level. Now, not just happens in the myocardium, but also things are going on in the nerve structure. Here's the left stellate ganglion, and you can see the protein levels in the left stellate ganglion is also increased significantly. This is the NGF and also the GAP43 proteins at about 3 days, 1 week, and one after myocardial infarction, and they persist for about a month afterwards. So we, based on this data, we believe that myocardial infarction causes a very early upregulation of nerve growth factor and many other neurotrophic factors around the infarcted myocardium. Then nerve growth factor is then retrograded, transported to the stellate ganglia through the axonal retrograde transport mechanism. So basically, the protein gets into the axon and then go backwards into the stellate ganglion. And the stellate ganglion then causes nerve sprouting of the entire heart. So if you do the histology of the atrium, it also has significant nerve growth. So NGF, even in a non-infarcted heart, there is increase in nerve growth. Those would contribute to increased contraction of the remaining portion of the myocardium, and it also may contribute to the arrhythmogenesis. Now, not only myocardial infarction, but also some major medical procedures such as radiofrequency catheter ablation, it clearly also causes cardiac nerve sprouting. So this is a sympathetic nerve sprouting induced by radiofrequency catheter ablation in dogs. So nerve sprouting occurs within 2 hours and was persistent at least 1 month after radiofrequency catheter ablation. So on the right, you can see that the right atrium 2 hours and right atrium 1 month. There's loaded with sympathetic nerves. Here's a higher magnification. You can see the right atrium of the experimental group of the dogs and the control group of the dogs. They're just control group dogs. You can find the nerves primarily around the blood vessels and very low nerves between the muscle fibers. And after radiofrequency ablation, there's a persistent nerve fibers pretty much everywhere in the right atrium. So both at the ablation sites and 2 centimeters away from the ablation sites of ablation, there was a lot of nerve sprouting. So this is in humans. Humans, we were able to draw blood in a pre-ablation, post-ablation, post-operative day 1 to day 6. With a different number of cases, and we tested their nerve growth factor. So we found that the nerve growth factor level continued to increase. And interestingly, is we found that after ablation, the AF recurrences was associated with increased nerve growth factor magnitude. So the higher the nerve growth factor, the higher the likelihood of a recurrent atrial fibrillation. So this is a cartoon on nerve sprouting after axonal damage. This is well known in the neuroscience field, and we just imported it to the understanding of cardiac arrhythmia. So this is a nerve growth factor after you have a axonal damage by ischemia or by cutting or by other mechanisms. The axon damages, and it will have local excretion of nerve growth factor and growth-associated protein 43. And these axons will then attempt to grow back to reinnervate the end organ. And there's a lot of nerve sprouts to ensure that the reinnervation occurs. And these nerve sprouts, when it does not form functional coupling with the end organ, they tend to regress, disappear. But a lot of nerve sprouts gets to stay. So for a long time, this nerve density is increased. So chronic substrate electrical stimulation can also cause nerve sprouting. So in addition to damage, electric current is actually known for a long time to be a growth factor for the cardiac nerves and for nerves everywhere. So this is we did the electrical stimulation of left stellate ganglion. So we put the electrode on top of the left stellate ganglion and give electrical current that does not change the heart rate or blood pressure in these dogs. And this subthreshold electrical stimulation, which get 43 synaptophysin and tyrosine hydroxylase, you stimulate subthresholdly in the stellate ganglion, but in the heart there's a lot of nerves. So electric current grows nerves inside the heart if you give the current to the stellate ganglion. So that's another cause of cardiac nerve sprouting is simply by having a lot of subthreshold electrical stimulation given to the stellate ganglion. So in this particular model that we published in 2004, the dogs, if the dog has AV block myocardial infarction and also has subthreshold electrical stimulation of the left stellate ganglion, then you create a high yield model of paroxysmal atrial fibrillation, tachycardia, VT, and sudden death. So here's your ventricular fibrillation. You have the sinus rhythm, or this AV block actually is some of the paced rhythm or accelerated idioventricular rhythm, and this is atrial fibrillation. So the dogs will generate the spontaneous atrial fibrillation throughout the time. But in addition, interestingly, they also have atrial arrhythmia as well. So with subthreshold electrical stimulation, you can also cause cardiac nerve sprouting. Now, a very important thing about these nerves is that the stellate ganglion not only innervate the heart, but it also innervate the skin as well. So the skin of the dog, if you inject the tracers, neural tracers at different parts of the skin, and you find where these tracers go back to, the cervical area and also upper thorax. In these areas, the tracer primarily go back to stellate ganglion. So that raised the hypothesis that the low amplitude subcutaneous nerve stimulation may be able to cause cardiac nerve sprouting, while high amplitude stimulation can damage the stellate ganglion, reduce sympathetic outflow, and control cardiac arrhythmia. So this is a method that engage in the skin to remodel the stellate ganglion. So here's the antiarrhythmic and the proarrhythmic effects of subcutaneous nerve stimulation in ambulatory dogs. So we did a study that we put the wire under the skin. In this particular study, we did it by visual inspection, trying to find a large subcutaneous nerve and put this electrode next to subcutaneous nerve. So then we prospectively randomize these 22 dogs, 11 male, 11 female, into 5 different output groups for 2 months of subcutaneous nerve stimulation at 0, 0.25, 1.5, 2.5, 3.5 milliamps. So it's the hypothesis actually is supported by this data. So the as compared to sham stimulation, the 0.25 milliamp stimulation has significantly increased cardiac nerves. Again, this stimulation is given to the skin, not directly to the subcutaneous tissue. So you can see this is a sham. This is a 0.25 stimulation, actually grows nerves inside the heart. But when you further increase the magnitude of the stimulation, the opposite occurs. At the 3.5 milliamp, you significantly reduce the number of nerves inside the heart. So the strength of the stimulation is important to cardiac nerve growth. So at the very low level of strength, you will actually grow the nerve, and a high level of nerve stimulation, such as 3.5 milliamp, to suppress the amount of nerves inside the stellate ganglion. So that actually transmits into spontaneous paroxysmal atrial arrhythmias. So this is the dogs, if you monitor them carefully, they actually have spontaneous PATs. This is a normal, PAT means paroxysmal atrial tachycardia, intermittent fast heartbeats. We define that by an abrupt increase of the heart rate in these dogs, or abrupt termination of the heart rate. You can see that with 0.25 stimulation, there are more nerves in the stellate ganglion, and there are more frequent PATs in this dog. Well, at 1.5, 2.5, 3.5, the duration of PAT and the frequency of PAT both all decreases. In addition, we did collect the norepinephrine levels from these dogs, and we did this blindly as to assess norepinephrine concentration. Only a dog who's 0.25 has pretty significant increase of circulating norepinephrine levels, and 1.5, 2.3, 3.5 is much less norepinephrine levels. So this suggests that there's a good match of the physiology with histology, that the very low amplitude stimulation grows the nerves and increases nerve activity and increase the circulating norepinephrines, while high output stimulation like 3.5 has anti-arrhythmic effect by suppressing the systemic norepinephrine level, as well as causes cardiac nerve to suppress the amount of cardiac nerves. So therefore, we summarize the mechanism of cardiac nerve sprouting. Number one is axonal damage, which is caused by myocardial infarction, radiofrequency catheter ablation, and this will be followed by increase in nerves. But low output electrical stimulation can also be followed by increase in nerves. However, axonal damage of large nerves may have opposite effect, as I will be presenting. So neuromodulation, because the relationship between sympathetic nerves and the cardiac arrhythmia. So there are a lot of enthusiasm to try to use neuromodulation to control the heart rhythm disorder. For example, vagal nerve stimulation, stellate ganglion block or ablation, renal denervation, the fat pad ablation. This is what people do during the atrial fibrillation ablation to isolate the pulmonary vein, but there are a lot of nerves around the pulmonary vein which was denervated at the same time. And it's commonly practiced acupuncture. Currently, I heard from acupuncturists that I know of, they always do electrical acupuncture, not just mechanical, and that appears to be more effective. As we just described, electrical acupuncture could result in nerve suppression of the nerve activity if the output is appropriate. So we develop an interest in measuring the sympathetic nerve directly in animal models. So this is the animal model of myocardial infarction, atrial ventricular block, and NGF infusion to left stellate ganglion. And we measure stellate ganglion nerve activity with bipolar electrodes and also subcutaneous nerve activity, because the subcutaneous nerve directly connect with stellate ganglion. So you can measure the subcutaneous nerve, which reflects the stellate ganglion nerve activity. That we found that it precedes the onset of ventricular fibrillation. So here is the stellate ganglion nerve activity and subcutaneous nerve activity. You can see a stellate ganglion nerve activity continues until this time when it just massively increased the nerve activity right before the onset of ventricular fibrillation. And after ventricular fibrillation, the dog has cardiovascular collapse, circulatory collapse. So there is no more blood pressure, and the dog is trying to compensate for the loss of blood pressure. So there's a massive activity in the stellate ganglion as well as in the subcutaneous nerves. And that massive activity happened to be associated with transition to from a less complex AF, VF, so-called the Wiggers 1 ventricular fibrillation into Wiggers 2 ventricular fibrillation. So this nerve activity might have rushed the calcium inside the cell. But unfortunately, because the dog is in ventricular fibrillation, it cannot increase the contraction. In humans, the first neuromodulation procedure specific for cardiac arrhythmia was reported in 1972 by late Dr. Arthur Moss. Dr. Arthur Moss just graduated from medical school. At the time, as assistant professor, he has a patient who has a very, very long QT interval of 0.64 seconds. And so he took the patient to the OR. And 83 minutes after local left stellate ganglion block, the QT interval shortens. So this implies that the stellate ganglion nerve activity controls the QT interval. So when nerve activity decreases, QT interval also decreases. Now, 40 minutes after right static ganglion block, QT interval actually increases. And 6 months after left cervical thoracic sympathetic ganglionectomy, QT of 0.44. And so this procedure, as shown over here, the patient had a baseline long QT, and after left static ganglion lidocaine injection, the QT becomes shorter. After right static ganglion injection, QT actually longer. And after static ganglion was removed, QT was shorter than baseline. Then patient remains asymptomatic for a period of time, actually for a long period of time. When I saw Dr. Moss, that was in right around 2008, 2009, he told me that this patient is still alive, has ICD, but does not have ICD shocks. So this is a unilateral thoracic sympathetic ganglionectomy is very effective in controlling cardiac arrhythmia and currently is indicated for drug refractory long QT syndrome and CPVT. And there are people working on using this method to control compound ventricular fibrillation. The other neuromodulation method is static ganglion block. The static ganglion is in the neck, which should be around the C7 and C8 or T1 area. But the vertebral artery goes, the course of the vertebral artery goes behind this clavicle in about C6. So the anesthesiologists think this is a safer area for injection. So they aim their needle at the C6 vertebra and they inject local anesthetic. Some people use lidocaine, other people use Marcaine, which is longer acting to inhibit the static ganglion nerve activity. And after the injection, this may control cardiac arrhythmia. So here's what happens to the static ganglion injection. So this is a skin sympathetic nerve activity that we recorded from the arm. And it depends on whether or not what you inject. So this is the static ganglion block that is injected. Then the skin sympathetic nerve activity, which was very active. After the static ganglion lidocaine injection, the activity abruptly reduces. And this is the integrated nerve activity. You can see the integrated nerve activity dramatically drops and heart rate is slightly decreased. In all the patients studied, you can see that before injection, the nerve activity was higher. And after injection, the nerve activity is lower for about 300 seconds. But instead of injecting the lidocaine, if you inject the saline, then the static ganglion nerve activity, the static skin sympathetic nerve activity actually may increase. So that proves two things. One thing is primarily the nerve on the skin is very connected to the static ganglion. And number two, the lidocaine injection suppresses temporarily the nerve discharge. So sympathetic outflow is decreased. But the problem is static ganglion is very far from the surface. So doing lidocaine injection obviously is very difficult. So what are the alternative ways to damage the static ganglion? I think the first thing that's used is the GP ablation, which is GP means it is ganglion plexi, which are the nerve concentrated nerves in the fat pad of the heart, which has a lot of nerve fibers. And in clinic, doing catheter ablation, the GP is often ablated. So there is a nerve structure called the ligament of the Marshall. And this is the left atrial appendage, left superior pulmonary vein, coronary sinus. The ligament Marshall was the embryonic left superior vena cava, which runs between left superior pulmonary vein and left atrial appendage. If you do histology of the ligament Marshall, you can see there are some nerve fibers, which is stained blue. There are also the left lateral muscle tract, which stains red. You can actually record the nerve activity as well as the muscle tract activity with a recording system. And there are plenty of different kinds of nerves. These brown ones are the ones that tyrosine hydroxylase is positive. These are the sympathetic nerves, not large nerve fibers going through this area. Actually, this is a connection between the stellate ganglion going through the ligament Marshall to innervate the free wall of the left ventricle. So this nerve fiber, this ligament Marshall is very important in terms of as a conduit of nerve fibers. So what we did in dogs is we did a GP ablation, which there are ganglion plexi in this fat pad around the heart. And we also identified the ligament Marshall, and we just cut out the ligament Marshall. So what we did is the first surgery, we did this ablation, and then we implanted the recorder to make a repeated recording. And also we did repeated left atrial stimulation to try to induce atrial fibrillation. In the past study in dogs with intermittent rapid atrial stimulation, the dog will go into spontaneous paroxysmal atrial tachycardia and fibrillation as during the follow-up. But if these stellate ganglion and the ligament Marshall are ablated, this will not happen. And if you look at the stellate ganglion, there are a lot of damaged stellate ganglion inside the ligament Marshall, inside the stellate ganglion, implying that when you do the GP ablation or stellate ganglion ablation, the results will affect the stellate ganglion far away. So how did that happen? Well, stellate ganglion is connected to the ligament Marshall. Therefore, when you cut the axon, there will be another, instead of the nerve sprouting, sometimes there's dying back degeneration. I'll show you a slide later. Now, before we go to that, we have another clinical procedure that is commonly performed for people with hypertension. This is called renal denervation. There is a large number of people who are doing this procedure and the research trying to find a way to treat hypertension. So here's a renal denervation. We did a study in normal dogs where we put first did an angiogram to highlight where the renal artery is. This is the right renal artery. Then we put the catheter into the renal artery and did multiple burns while the catheter is being drawn back. And finally, we did another angiogram, which showed that there was no evidence of stenosis. Actually, this is a very safe procedure for humans with the same technology. The humans do not have significant side effects with this renal denervation. But what is most interesting is if you look at the stellate ganglion, there's a lot of evidence of stellate ganglion damage induced in dogs with renal denervation. This is a tunnel stain. Tunnel stain stains the fragmented exposed DNA. So when tunnel is positive, it implies that the cell is dead. So in the left stellate ganglion, there are a lot of tunnel positive ganglion cells. These ganglion cells are the cells that produces tyrosine hydroxylase. So immunostaining clearly shows that the stellate ganglion has a lot of dead cells after renal denervation. And these findings in dogs actually correlate very well with the clinical study. So this is by Dr. Jonathan Steinberg of New York. He ran a prospective randomized clinical trial showing the effect of renal denervation and catheter ablation versus catheter ablation alone on atrial fibrillation recurrence among patients with paroxysmal atrial fibrillation and hypertension. So all these patients have hypertension, and so they have they may benefit from renal denervation to control their blood pressure. But when they also have atrial fibrillation, they recruit them into the study to randomize them into getting renal denervation or no renal denervation. But all of them have catheter ablation by pulmonary vein isolation. So if the pulmonary vein isolation alone, the recurrence of atrial fibrillation, flutter, or tachycardia was about 40% in a year, which is not too far away from most of the people's report. There's paroxysmal atrial fibrillation with hypertension. You do not get 100% success by pulmonary vein isolation. But if you the group was randomized to pulmonary vein isolation plus renal denervation, there is a massive reduction, about 1/3 reduction of AF recurrence. So the implication is that the renal denervation assist or add to the pulmonary vein isolation. And based on a dog study, I think what happens after renal denervation is the stellate ganglion remodeling, because the stellate ganglion has remodeling and reduced sympathetic output and result in a less occurrence atrial fibrillation. So the third method of performing neuromodulation to the stellate ganglion is rapid electrical stimulation. As we said before, rapid electrical stimulation at high output from the skin can suppress the sympathetic nerve activity. In the brain, this has all been very well studied in neuroscience. In the brain, the investigators studied in 14 rats 2 to 20 hertz of 24-hour stimulation of the axon in the peripheral path. That will cause seizure and cell death in the central nervous system. Peripheral path is the axons of the nucleus on the other side. So very similar to you stimulate or cutting the renal nerves. So then you take the histology, and they found that there's the findings closely resemble the excitotoxic type of damage that is induced by glutamate aspartate. So let me, so this is a group of neurons. You can see these are very dense pycnotic nuclei, are very typical, and also these findings in the electron microscopy are very typical for the excitotoxic type of brain damage. So what is excitotoxicity in the brain? Well, brain uses glutamate as a neurotransmitter. So when the cell dies, the glutamate is released that continue to excite the neighboring cells and causes neighboring cell to die of too much excitation. And this process can go on and grow, to continue to progress and cause enlarged damage. This is one of the mechanisms people thought was responsible for Alzheimer's disease. And so therefore, blocking this pathway is one of the 2 drugs that is FDA approved to treat Alzheimer's disease. So what happens to the electrical stimulation is very similar to this, is that you stimulate the axons, then these neurons get signal to excite all the time and have calcium accumulation. And just like during the persistent exposure to glutamate, and this calcium accumulation causes cell death. Their histological features are very similar to each other. So we test this hypothesis by doing a blind incision of subcutaneous electrode. Actually, we did quite a few studies, but in this particular study, we used the blind insertion subcutaneous electrode. So this is a surgical wound, but the electrode actually inserted blindly under the skin of the dog. And we trust that there are many nerves under the skin. And as long as we stimulate some nerves, the stellate ganglion will be going into rapid activation and will generate toxicity to the stellate ganglion. So here is what happens before stimulation. Here's a spontaneous static ganglion nerve activity, and that's associated with PAT. So this is sinus rhythm, PAT, and sinus. So static ganglion, when it fires, it causes tachycardia. But during respiration, you can have intermittent static ganglion activity. You have intermittent increase of the ventricular rate. But during subcutaneous nerve stimulation, when you stimulate, you can see the heart rate goes up and progressively reduces. So the subcutaneous nerve stimulation actually directly affects heart rate and the static ganglion nerve activity. You can see the static ganglion nerve activity was abruptly terminated. Subcutaneous nerve stimulation also increases fibrosis and eosinophilia in the static ganglion. Eosinophilia is a histological sign where during the HE stain, hematoxylin will be overly staining the cell and cause the cell to look very red and pink. So this is in these cells on the 3.5 milliamp stimulation, you can see compared to sham control, they are red-pink stimulation, but this is much denser, much redder than the sham. So these cells, especially these, are clear dead cells. So we found the percent of fibrosis, which are stained blue, is a significant increase with 3.5 milliamp stimulation. But in the right static ganglion and left static ganglion. It's also interesting to see the male dogs seems to respond better than female dogs. The mechanism is unclear. But in dogs with persistent atrial fibrillation, when we measure the heart rate is lower. And the post-stimulation, the left ventricular ejection fraction actually becomes better. So it also affects ventricular function by better heart rate control. So here's the several possible different changes as a summary. So we talked about when there was a the nerve is known to remodel itself. So when there is no need for this nerve to innervate here, but you need this nerve to innervate here, you would cause a reduction of this nerve, and this nerve will regain the control of this end organ. And this is normal. In neurodegenerative disease, what happens is that the axons dies. It will have this die-in-back degeneration resulting in cell death. So you cut axon, there may be two different consequences. One is that some axon cutting and local tissue like heart will produce nerve growth factor. It will cause nerve sprouting because the nerve trying to re-innervate the end organ. Alternatively, this nerve may die by die-in-back degeneration cell death. And I think that's what happens after renal denervation or after rapid cutting of the venous marshal, and that causes retrograde cell death and remodel the static ganglion. So there are some major pathways that underlie axonal pruning and die-in-back degeneration. So number one, as I just talked about, this trophic factors, nerve growth factor, electrical stimulation. But there are also protein degradation, caspase activation causes apoptosis. There are neural and glia interactions and the balance between degeneration and regenerative forces. This is very important. As I discussed, sometimes the nerve wants to regenerate, but other times there is a degenerative forces, and the balance between the two results in neural remodeling, the end organ neural remodeling. So in summary, I think the neural remodeling, so far the clinically applicable neural remodeling are as follows. Number one is we do rapid electrical stimulation of nerves, which causes intracellular calcium accumulation and neuronal cell death. So that's one method. The other methods, axonal damage, can be followed by die-back degeneration and neuronal cell death. This happens in the pulmonary vein isolation or vein or marshal ethanol infusion, and also occurs in patients undergoing renal denervation. So that's a quick overview of neuromodulation as requested by Dr. Olivier Bernes, and I hope this is helpful to you. I think I'll use the rest of the time for discussion. Thank you.
Okay, thank you, Peng. Any questions from the students? Well, maybe I can start off a little bit of the discussion. Peng, just in the last part, when you do the skin sympathetic nerve stimulation, so as it's written there, it can lead to neuronal cell death. Did I understand correctly that it induces myocardial fibrosis? Yeah, here.
Yes. So it induces the stellate ganglion fibrosis.
It's stellate ganglion. It's not in the myocardium.
No.
Okay. Because I was going to ask if that could not be an arrhythmic property then, but okay. So I had one other question, two other questions. One question is related. They have not had yet the courses about ventricular fibrillation and atrial fibrillation, in at least not in detail, but just anticipating on this, in ventricular fibrillation, one major structure of interest is the conduction system, the Purkinje fibers. And we have a lot of ectopics coming from the Purkinje that can trigger ventricular tachyarrhythmias. Right. Of course, in CPVT, for example, this has been linked to catecholamines, but any evidence or any hypothesis that could link nervous activity to Purkinje ectopic activity?
Well, the Purkinje ectopic activity typically is associated with very short coupling of PVC, right? So it occurs, the PVC occur right in the middle of the T wave. In theory, the action potential duration is very much related to the occurrence of this sympathetic nerve activity. So specifically, sympathetic nerve activity will activate the calcium-dependent. First of all, you increase the number of calcium. It will phosphorate the calcium handling proteins, so the cycling of the calcium is much faster. And then you will activate the potassium currents. There are two currents primarily respond to sympathetic stimulation. One is IKS, and the other one is ISK, the small conductance calcium activated K current. And when sympathetic stimulation occurs, depends on the balance of the depolarization and repolarization forces. I think it's more likely to generate activity. So specifically, for example, when you have more calcium, it could causes trigger activity that could occur from the Purkinje system. Purkinje and the myocardium have a different electrophysiology, quite different. And I think Purkinje, the problem with Purkinje, as you know, we try to study Purkinje. It's a very difficult preparation to make.
Yes.
So even with pennyboyden here, it has not been really successful in getting a preparation going. I think that's really key. I really encourage, we will hope that we will be able to do it together to understand how the Purkinje responds to stimulation.
But do you have any indirect evidence in your or animal models? I don't know if you have a good animal model of Purkinje ectopy, but in vivo, where you denervate, that it reduces the burden of Purkinje ectopy. Is there any evidence of that somewhere?
The only Purkinje study I have done was a rabbit preparation where we actually separately recorded Purkinje myocardium and also Purkinje and the myocardium, and the Purkinje activation and the myocardial activation are different. The slope activation was in part determined by the SK current.
Yeah.
So no, we have not. I really wish that we have done more on the Purkinje. That's actually a very interesting project.
Yeah. Okay, pass on the microphone to student.
Thank you for the presentation. I'm sorry if the question is stupid, but when you stimulate the stellate ganglion, you stimulate the sympathetic neural system, and what there is effect on the atrial fibrillation and the atrial activity. But what are the side effects? Because I imagine it affects all the sympathetic system, and people are getting some vagal syndromes.
Yeah. So first of all, your question is never stupid. I think your question is very good. Thank you for asking this question. So the question, my understanding of your question is what happens when you stimulate a nerve, and also the interaction between autonomic two arms of autonomic nervous system. So when you stimulate sympathetic nerves immediately, stellate ganglion is stimulated immediately. Actually, one of the first things is heart rate will go up, and also the blood pressure will go up. So to answer your question, it does occur not only that the ventricular fibrillation is more likely to occur, but also atrial arrhythmias is more likely to occur because of a heightened sympathetic tone. I think you mentioned about vagal nerve stimulation. So how does vagal nerve stimulation affect the stellate ganglion? Well, one thing very important to know that I did not include in my slide is that the vagal nerve contains a significant amount of sympathetic fibers. This is actually known for a long time because the vagal nerve has always been called as a sympatho-vagal tract. So if you do a cross-section of vagal nerve, there are parasympathetic nerve fibers, sympathetic nerve fibers, the muscle fiber, the motor neurons, and the sensory neurons. So it's a very complex structure. So when you do vagal nerve stimulation, you're still stimulating all of them. And one effect of vagal nerve stimulation actually is damage to the stellate ganglion.
Okay. And the second question, but it's more curiosity. When you stimulate the subcutaneous nerve, what are they feeling some pain, or is it painful?
Yes. Yes. Yeah. Very good question, and only I have the answer.
Okay.
Because I'm doing a clinical trial stimulating the human beings, the subcutaneous tissue. Most of the patients at the 3.5 milliamp, when stimulated, only have mild uncomfortable. So mild sensation, it doesn't affect them. But the one patient that I have done has a pretty severe response. She's got goosebumps. She got the sweating. So all these are sympathetic stimulation. So, and also pain. So it depends on, really, I think this in part depends on where the stimulator is.
Okay.
Yeah.
And we couldn't think that the pain would stimulate the sympathetic nervous system with cortical effect, like corticosurrenal effect and everything, which is not directly linked to the satellite ganglion. Like it's more a systemic effect.
Yeah, I think that's a very good point. But you remember the stimulator that we use for human studies is primarily for the pain control. So sensory nerve has this characteristics. If you stimulate the pain fiber or sensory nerve, excuse me, it will desensitize the pain fibers. So in all patients I studied so far, the pain doesn't last very long. It's only a few days. It's not painful for the rest of the stimulation. Rather, it's initially is painful, but then the sensory nerve also remodels and become insensitive to pain stimulation.
Okay, thank you.